Assistant Polly with Maryville University, and this is my head-to-toe assessment. This is Mike, and he has volunteered to be my patient today. Before we got started, I had him empty his bladder and put on a gown. After that, I obtained a full set of vitals and height and weight. I assessed his near vision with the Rosenberg chart and his far vision with the Snellen chart. To get started, I am going to begin with the face and head. I am going to inspect the face for symmetry by inspecting the eyes, nose, mouth, and ears, ensuring that they are symmetrical and even on the face. I am inspecting the skin for any lesions, masses, nodules, and I am also inspecting the skin for uniform color. After this, I am going to palpate the scalp. I am feeling that the skull is normocephalic. I am palpating for any masses or lesions that may be present on the scalp. I am also palpating that the scalp is freely movable. After this, I am going to note hair color and distribution pattern along with hair texture. After this, I am going to palpate the facial bones and sinuses, including the frontal, ethmoid, and maxillary sinuses. After this, I'm going to palpate the temporomandibular joint by having him open and close his mouth, noting any crackling, popping, or tenderness. Any tenderness?
No.
After this, I am going to assess light sensation by having my patient close his eyes and tell me where you feel each
Forehead, left cheek, chin, right cheek, chin, forehead.
Great. After this, I am going to move on to the cranial nerves. I will have my patient wrinkle his forehead, close his eyes, smile, clench his teeth, stick out his tongue, and puff out his cheeks. Next, I am going to move on to the eyes. I'll first inspect the eyes to ensure that they are symmetrically placed on the head. Next, I am going to ensure that the lashes extend outward and upward. I am also going to inspect the eyebrows, ensuring that they extend evenly on the face, noting hair distribution pattern, color, and texture. After this, I am going to inspect the eyes for any periorbital edema or redness. Then I am going to inspect the sclera and conjunctiva, noting any redness or drainage. Then I am going to palpate the lids and lacrimal apparatus, noting any tenderness or nodules present. Any tenderness with that?
No.
Next, I am going to ensure that his pupils are equal and reactive to light, both directly and consensually, by having him pick a spot on the wall to look at. And I am going to note direct, consensual, direct, consensual. Great. After this, I am going to elicit the red reflex with the ophthalmoscope. Great. Next, I am going to have my patient cover one eye. And I am going to examine the uncovered eye for any nystagmus, involuntary movements, or deviations, and now cover the other eye. And once again, I am examining the other eye for any nystagmus, involuntary movement, or deviations. Next, I will have you focus on the end of my pen light and follow it with your eyes. I am assessing the 6 cardinal fields of gaze. And once again, I will note any nystagmus or involuntary movements. After this, I will have you once again cover one eye. And please tell me when you can see my fingers.
Now.
Okay, now cover the other eye. And tell me when you can see my fingers.
Now.
And the confrontation test was to assess peripheral vision. Next, I will go to the nose. I am first going to inspect the nose for symmetry and configuration on the face. I am looking for any lesions or nodules that may be present. Then I am going to use my pen light to inspect that the septum is midline, that the nasal mucosa and turbinates are pink and moist, that there are no nodules, redness, or drainage present. Then I will have my patient occlude one nostril with a finger and blow out the other, and repeat with the other nostril to ensure that both nostrils are patent. Next, I am going to move on to the ears. I am first going to inspect the ears, noting their alignment and placement on the head. Then I am going to inspect the ears for any nodules, lesions, masses, or rashes that may be present. Then I am going to palpate the auricle, noting any tenderness or nodules present. Any tenderness with this?
No.
Then I am going to visualize the tympanic membrane with the otoscope, noting that it is pearly gray and that the internal structures are visible. At this time, I'm also inspecting the ear canal, noting any redness or cerumen present. After this, I am going to perform the whisper test by having my patient cover one ear and repeat what I say.
Orange.
And cover the other ear.
Banana.
Great. After this, I am going to perform the Weber test. I will strike my tuning fork and place it on top of my patient's head and have him tell me if he can hear it in one ear or both.
Both.
Great. Next, I will perform the Rene test. I will strike my tuning fork and place it on the mastoid bone. I will have him tell me when he can no longer hear the vibration and move it in front of his ear, and once again tell me when he can no longer hear the vibration.
Now. Now.
Great. And that is a normal finding, as bone air conduction should be twice as long as bone conduction. Next, I am going to move on to the mouth. I am going to inspect the lips, buccal mucosa, hard and soft palate, and gums for any redness or lesions or swelling. After this, I am going to inspect the tongue, noting any cracking, redness present, and noting that it is freely movable. Next, I am going to have my patient turn his tongue side to side and up and down, noting any oral cancers that may be present. After this, I am going to inspect his teeth, noting the number and color, also noting any visible cavities that may be present. At this time, I am also noting the patient's breath for any odor. Next, I am going to assess the oropharynx, noting the anterior-posterior pillars, tonsils, uvula, and posterior pharynx. After this, I will have my patient say ah, noting that his uvula rises midline and that his soft palate rises symmetrically. After this, I will perform the gag reflex, noting that it is intact. Next, I am going to move on to the neck. First, I will inspect the neck for symmetry and smoothness. Next, I am going to inspect the trachea, ensuring that it is midline, that there is no obvious thyroid enlargement, and for any jugular vein distension. After this, I am going to palpate the neck for any tenderness or masses that may be present, any tenderness.
No.
Then I am going to palpate the trachea, noting that it is midline, and having him swallow, noting that the thyroid does rise even bilaterally, and noting that it is of normal size. Then I will palpate the carotid arteries. Next, I will palpate the lymph nodes, starting with the preauricular, postauricular, occipital, tonsillar, submandibular, submental, superficial cervical, deep cervical, posterior cervical, supraclavicular, infraclavicular, and axillary. Next, I am going to auscultate the carotid arteries and the thyroid, noting any brewery thrill. Next, I am going to have my patient turn his head side to side, ears to shoulders, front and back, noting range of motion, and then I will have him push his head against my hands and rise his shoulders, noting strength. Next, I am going to move on to the anterior chest. First, I am going to inspect the anterior chest for any rashes, masses, lesions, or nodules. Then I am going to inspect my patient's respiratory rate and rhythm, noting that it is non-labored and within normal limits. After this, I am going to inspect that chest wall rises symmetric bilaterally, and also inspect for any accessory muscle use or retractions. At this time, I'm also inspecting for any pulsations or heaving that may be present. After this, I am going to palpate the patient's anterior chest, noting any masses or tenderness that may be present, any tenderness.
No.
Then I am going to assess the patient's tactile firmness by having him say 99.
99. 99. 99.
Then I will palpate the precordium, noting any pulsations or heaving, and the apical impulse, noting that it is at the 5th intercostal space, midclavicular line. Then I will percuss the patient's anterior chest and lateral chest, noting any hyperresonance or dullness, along with noting that it is symmetrical bilaterally. After this, I am going to auscultate the patient's lung sounds, noting any adventitious breath sounds, such as crackling, wheezing, rales, rhonchi. I will also listen to the patient's lateral chest. After this, I am going to listen to the patient's heart tones, starting with aortic, pulmonic, herbs, tricuspid, and mitral. Great. Now can I have you turn around so I can examine your posterior chest? Starting with the posterior chest, I am going to inspect for any rashes, masses, lesions, or nodules that may be present. Then I am going to, once again, inspect for symmetrical chest wall rise, inspect for any accessory muscle use, inspect that the respiratory rate and rhythm are non-labored and within normal limits. After this, I am going to palpate the posterior chest, once again noting any tenderness or masses that may be present, any tenderness.
No.
Then I am going to, once again, assess tactile firmness by having the patient say 99.
99. 99. 99.
Then I am going to assess thoracic expansion by having the patient take a deep breath, and noting that my hands do rise even bilaterally. After this, I am going to percuss the patient's posterior chest, once again noting any dullness or hyperresonance that may be present. Then I am going to assess the patient's diaphragmatic excursion by having him take in a deep breath and holding it, and making a mark when I go from resonance to dullness. You may take a breath, and then have the patient exhale and hold it, and making a mark when we go from dullness to resonance. You may breathe normal. I will then measure this, as it should be between 3 to 5 centimeters, and his is 4. I would then repeat that on the opposite side, and both sides should be symmetric. After this, I am going to percuss the costovertebral angles, noting any tenderness. Do you have any tenderness?
No.
Great. Then I am going to auscultate the patient's posterior chest. Once again, noting any adventitious breath sounds, such as crackles, wheezing, rales, or rhonchi. Alright. Now you may lay down as I move on to the abdominal assessment. First, I am going to inspect the abdomen for any rashes, lesions, or nodules that may be present. Then I am going to take my pen light and assess the abdominal contour, along with any pulsations that may be present or peristaltic movements. At this time, I am also looking for any masses that may be present. Next, I am going to auscultate vowel sounds. I am going to listen in all 4 quadrants for up to 2 minutes in each quadrant. Then I am going to auscultate the patient's aortic, renal, iliac, and femoral arteries. Next, I am going to percuss the abdomen, once again listening for any dullness or hyperresonance. Then I am going to percuss the liver borders, and I am going to percuss for splenic dullness. After this, I am going to lightly palpate the abdomen for any tenderness or masses that may be present. Any tenderness?
No.
Next, I am going to perform deep palpation. I am going to start with the liver, then the spleen, then the kidneys, then the aorta. And then I'm going to have my patient pull his shoulders up off of the exam table so I can palpate the abdominal muscles. You may relax. Next, I will move on to the upper extremities. So you may sit up. I'm first going to inspect the upper extremities, noting any rashes, masses, lesions, or tenderness that may be present. At this time, I am also inspecting the extremities, assuring that they are uniform in color bilaterally. I am going to inspect the hands and nails for any clubbing or cyanosis. I also am inspecting to ensure that capillary refill is less than 3 seconds. After this, I am going to palpate the upper extremities, noting any masses or tenderness that may be present. Any tenderness?
No.
Next, I am going to assess light and sharp sensation by having my patient close his eyes and tell me which you feel.
Light. Sharp. Sharp. Light.
Great. Next, I am going to palpate my patient's brachial and radial pulses. And then I will elicit deep tendon reflexes. Can you relax your arm? Great. Next, can you please hold your arms out and don't let me push them down. Don't let me pull them up. And then squeeze my fingers, noting upper extremity muscle strength. Now I am going to move on to the lower extremities. First, I will inspect the lower extremities for any rashes, masses, lesions, or tenderness that may be present. Then I am going to inspect them for any edema or swelling. At this time, I'm also inspecting that color is uniform between both extremities. I'm also noting hair distribution pattern in both extremities. I'm going to inspect the toes and nails for any clubbing, cyanosis, and ensuring that cap refill is less than 3 seconds. Then I am going to palpate the legs for any tenderness or masses that may be present. Any tenderness?
No.
Then once again, I am going to assess the patient's light and sharp sensation by having him close his eyes and letting me know if it is a light or sharp sensation.
Light. Sharp. Sharp. Light.
Great. Next, I am going to palpate the patient's dorsalis pedis pulses, posterior tibial pulses, and popliteal pulses. After this, I am going to elicit the deep tendon reflexes. Next, I am going to have the patient pull his feet up, push down. Great. Now you may stand and bend your back and neck. Here I am assessing the cervical, thoracic, and lumbar spine, noting the curvature and noting that both sides of his back are symmetric. You may stand up normal. Please Close your eyes and balance on one leg. Great. Now open your eyes and walk with a normal gait. Great. Thank you very much. That concludes my assessment.